you like falafel?
I do. Yes.
So my son is a graduate of George Washington University, but I am convinced that he preferred M Street way more than Foggy Bottom. Yes. And there are only two places that I will eat falafel in D.C., and one of them is at the corner of M Street and Potomac. And the shop is literally called Falafel, and there's no sign on the window. There's no sign over the door. They put a little a stand out in front when they're open that says falafel, and the line goes out the door, down the street, down M Street, and clearly the food speaks for itself, and so they don't waste any money on marketing or branding, right?
I think I've seen it, actually. I know exactly the corner you're speaking of.
I hope you get to go there soon now that I brought it up. Hello, and welcome to the Fire Chief Podcast, the only podcast dedicated to the Chief Medical Officer. I'm your host, Lee Scheinbart, and this podcast features stories and wisdom from some of the best CMOs in healthcare. These leaders face some of the toughest challenges in healthcare right now, and they will share with you their insights, how they do that. Today, our guest is Dr. Mohsin Shabahang, the Chief Medical Officer of the Surgery, Anesthesia, and Perioperative Care Service Line at WellSpan Health in South Central PA. We're in South Central PA.
We're centered in York, Pennsylvania, with the adjacent counties, the 5 counties south of Pennsylvania.
Got it. I know where that is. And you grew up in Tehran, Iran, until age 15, right?
Yes.
And you spent a year in Spain, and then the next 19 years in Washington, D.C., right?
Yes.
You attended Georgetown, and you earned both your undergraduate and your medical degree, and you went on and trained there as a resident in general surgery?
Yes. And I got a graduate degree during that time, too. So all my degrees are from Georgetown.
Yeah. Tell me about your graduate degree. You have a PhD in what field?
In biochemistry and molecular biology.
And that was also at Georgetown?
Yes.
Okay. Excellent. And then you went to the University of Miami, where you completed your fellowship in surgical oncology, correct?
Correct.
And so there you have it. That's the background. So welcome to the show.
Thank you so much. Appreciate being here.
Absolutely. We still have to establish a couple more things before we get too far into the show. You did spend, obviously, a good portion of your younger years in Washington. And I'm curious to know, do you still have any relatives that live there?
I do not. I still love the city and try to travel there anytime I can. But no, I don't have any. It's some friends still.
Gotcha. So you trained as a surgical oncologist, right?
Yes.
And so the listeners probably know by now that I was a former medical oncologist. And while our radiation oncology colleagues use laser beams, I use those liquid toxic chemicals to treat cancer. But you used cold, hard steel, right?
Yes. In the days of open surgery, and yes, I did.
And what was there a tumor type or an area of focus that you specialized in?
Yes, I was doing mostly upper gastrointestinal, some skin, and breast cancer. But my favorite operations involved the pancreas and doing pancreatectomies of different types.
Oh, you are a rare breed. Not everyone has been formally trained and skilled in the types of work that you're talking about. My hat is off to you.
Thank you.
You're welcome. So tell our listeners, so what happened to you from the time you were an early surgical resident and a surgical oncologist and made your way to becoming a chief medical officer? Give us that story.
Yeah. No, it's interesting because my background is pretty simple. I've had 3 jobs at 3 different healthcare systems. I started at what now is Baylor Scott and White in Temple, Texas. At that time, it was called Scott and White. I was there for 8 years. I was at Geisinger for 11 years in North Central Pennsylvania, and I've been with WellSpan for about 3.5 years. I do say that in that period, I've had really 3 15-year careers. And I know that the numbers don't add up because they overlap.
Nobody's counting, Mo. It's perfectly okay.
Like, well, 3 times 15 is 45. But I had 15 years as a busy clinician. And it was a time that was interesting because it was a time of going from general surgery practices to more specialized practices. So I had 15 years between Scott and White and Geisinger. Then I had 15 years as a surgical educator. I led 2 different general surgery programs for about 16 years. And then I've had 15 years as a healthcare executive. So I've been fortunate to experience 3 different phases of a medical career.
The executive career, that's the one we're going to focus on most of the show here. And you mentioned your PhD. You do not have an MBA, correct?
No, I do not.
We're also alike in that regard. So in addition to treating folks with aggressive malignancies, we both went into executive roles. And folks in the oncology field, when they do that, tend to go into the major NIH Cancer Center programs and become executives over those systems. But you and I broadened out a little bit, and I did not pursue an MBA. Tell me, were you counseled in that regard? Did people talk to you about that? What were your thoughts relative to a business degree?
I think that if I had to redo it, most probably I would think about an MBA, a Master's of Health Administration, a Master's of Organizational Dynamics and Psychology, something that would help me in the leadership arena. But it's interesting. Careers sometimes are very linear, and you know exactly what you want to do. And there are times where it's just what comes your way, and you morph. I actually pursued a master's in healthcare education. And I will say one of my things is that I did all the coursework and I changed jobs at that time, so I never finished the capstone project. But I felt that was going to be important, and it was. I think that there are many people who get Masters of Health Professions education, and I think it's a wonderful way to go. Do I feel that, an MBA is absolutely essential? I'm not sure if it is. I think some sort of a higher education, I think, opens the mind to different aspects of leadership.
Yeah, I like the way you're framing that. I have also contemplated the role of that advanced education, but along the way, like you, career paths shifting, and things happen in one's life, so it doesn't always work out so perfect. It does seem to, and I know because you and I have talked in the past and others that we are mutually acquainted with, that CEOs, non-clinical CEOs in particular, tend to look for that on a CV as though that is a qualifier. And one thing I would hope over time is that as physician leadership grows and physician executive careers open, that physician CEOs will determine that an MBA is not always that helpful. Now, an MHA or public health, those have real tangible value. But honestly, I'm never going to go to London to talk to a banker about a bond rating for my health system. So why do I need to study that in my MBA course? I'm going to learn management skills for sure. But I mean, some of the finance things are beyond what you need to become a successful physician executive, right?
100% agree. There's so many aspects to being a healthcare executive that there's no way you can master every one of them.
That's right.
And say, well, I've gotten, you're going to need 5 different degrees before you can do that. So I do worry about, in general, litmus tests of people for different positions.
And look, it's hard enough to get into the pre-medical curriculum and do well, medical school, all of the training, fellowships, PhDs notwithstanding. I mean, come on. I mean,
and Leah, if I may, I'll say this. One of the models that I use the most in administrative work is the model for curricular development, because that concept of the goals and objectives and what methodology are you going to use, and then how are you going to reevaluate, that pathway applies to many projects that we undertake. And that was never designed for leadership, and yet it applies so well.
Oh, I totally agree. And curriculum mapping is a requirement in education, right? You know that, as you just stated. And yes, it helps you from a project management standpoint as a leader. You exactly how you describe where you want to be. You manage by objectives. Everything maps to that, so that we always know where we're headed to get to the conclusion. And then we've done that initiative and we move on to the next, because in healthcare, there's always a new initiative that you're going to deal with. Just like in medical education, there's new knowledge, there's new skills, there's new things we're applying to the care of people. I want to ask you, as you went through this journey and these 3 15-year career steps, who and you don't have to name names, who was influential to you, who helped you along the way? Role models, mentors, coaches, that sort of thing.
Absolutely. There was one person who it all kind of all the stories come to someone who saw something in you that maybe you didn't see in yourself. And that really started when I was in medical school and residency, and a lifelong mentor who's actually the CMO at MedStar, Steve Evans, kind of saw something in me as a medical student and a resident. And I was in his lab for 5 years. And that was really a beginning of someone seeing that, hey, this guy actually can be a surgeon. I think the next...
Bo, they didn't see that in me. I was not meant to be a surgeon, and that's perfectly fine. So please go on.
We're all, they're meant to be different things. I think then it came one of my chairs, Roy Smythe, who basically said, Mo, you really are into this education thing. Have you thought about being our program director? And at that time, I was 3 years into my career, and I'm like, sure, if you see the potential. And once again, here was a sponsorship of someone saying, I think I see something in you. And I have a rule that when life is a series of sponsorships and serendipity, and if you get lucky enough, remember that you need to then earn the right to be that. So I really went after studying, how can I be the best educator I can be? And so I knew that the chance was given to me a little bit earlier than maybe I deserved it. And then there are many people, but then I came to Geisinger, and our CEO at that time, Dr. Glenn Steele, day one, he said, Mo, at that time I was a division leader, so I was several layers away. He said, I'm going to meet with you every other month. And he did, despite the busyness of his schedule. And that was very influential, because every conversation that were no more than half an hour, I would think about it. And there were things that he was pointing to me, positive and negative, that was really consequential. And then when my chair at that time, Dr. David Franklin, left, he said, I've recommended you to be the interim chair. And I went on to get the permanent position. But that was also an opportunity that I wasn't sure that I was ready for it, or that necessarily I deserved it. But I worked hard at earning it. I just felt that. So I feel like throughout our careers, there are all these opportunities, and you do need those mentors, those sponsors, and coaches that help you through these junctures, who see something in you that sometimes maybe you didn't even see, or see something in you that maybe you knew you have it, but no one else was willing to give you that chance.
Yeah, that is a common theme amongst the CMOs that we talk to on this show, and for many physician leaders, for that matter, medical director, program director, that someone sees something in us. Hey, you're a great guy. You're easy to talk to. You're smart. You educate well, and you get the tap on the shoulder to take a role. And that's where it can get really fuzzy, because sometimes not everyone is in the frame of mind as you are to both go out and earn it and or have people to help teach you and apprentice you, just like we do in our training. And that's sort of a fork in the road. We're used to being the apprentice and then the teacher, but in the executive trajectory, it sometimes gets fuzzy. And I work very hard in our leadership curriculum to make sure that people know that there's an intentionality to your point. And I'm going to borrow that phrase, that people make sure that they earn the responsibility that's bestowed upon you when someone taps you on the shoulder. You may have noticed in my introduction that, and I do this with all of the guests, I recognize that people earned their degrees. My grandmother, may she rest in peace, used to say, if anybody ever asks you where you got your degree, you stop and correct them and tell them you earned it. Nobody gives you anything in life. Yeah. You earn it. So you are a master and you have an insight as to how to really be intentional about a career. So it's good stuff for our listeners. Thank you.
Well, and if I may just add,
Absolutely.
I like models, and there's this kind of concept of team that Patrick Lencioni put out, that you're hungry, humble, and smart. So you have to earn that competence, but you also need to show the hunger that you're ready. You're put me in, coach. I'm gonna make it good for you, whatever I need to do, and that you have that humility that this wasn't a privilege that was owed to me. It's what I've earned, and I will continue earning it through the years to come.
I have used that it was taught to me. I'm familiar with it, and I use it when I teach about how to hire somebody. Look for somebody who's humble, hungry, and smart. And then, of course, everybody says, well, everybody's smart. Well, this is not the intent of what Patrick meant by smart. Do you remember what he was meaning?
I see it more as a competence in that, but please, I'm not recalling exactly.
Yeah, what I believe that he has suggested by smart is emotional intelligence.
Yes.
So all of our non-clinical and clinical administrative colleagues are smart. You can't get to these places without some IQ. Now, it doesn't have to be off the charts. But you don't always find the EQ, the emotional intelligence. And that's what I think Patrick meant in his writings, that humble, humility, hungry, you're going to work hard, you're not out for the title or you're hungry to do the work that's in front of you, and you're smart about the work and what people mean to you and that sort of thing. So speaking of these kinds of competencies, let's dig into what you may have felt was the hardest thing you have faced in your leadership role. Aside from COVID-19, what was the hardest thing you have faced?
Most of it has to do not with the crisis at hand. I think most of it has to do with how you perceive yourself dealing with it. I remember there was a situation where this was about 12 years ago, where I was a young leader 3 years into really kind of leading a division and a department. And I suddenly had the awareness to know there's a crisis of confidence, but I couldn't understand why. And so I knew there was a lot of rumbling going on. And that was really difficult because I didn't understand why. And that philosophy that you bring into it, that I'm working hard, so, what could be the issue? So I got the group of 50 people in a room, and I stood at the board and said, for the next hour, you tell me everything that you see as a problem. And I'm not going to even respond. I'm not going to get defensive. I'm going to write it on the board. And I will say that was hard. It was essential, though, because you realize that what's difficult is when you question yourself as to whether you have the right competencies, whether you're doing it right. And I think the most important thing that evolved of that was that you don't get one shot at this. This is a long-term marathon that you need to keep trying to improve. So even though that evening was difficult, there were lessons I learned that went on. I think the other piece that's very difficult, again, it's not one crisis. It's as you as a leader, being a change maker, when do you know when to keep pushing and when do you know to maybe pull back and say, I need to listen a little bit more? And I have this, I kind of like this phrase, I call it the leader's prayer, is let me know when to keep pushing because I need, they're not seeing it. I need to lead and be a leader with courage. And when should I listen more and maybe pull back? And there are times where you see as a leader, you start a change and you immediately withdraw. And there are other times where you just persist, despite the fact that your advisors and others come in and say, we need to stop this. And I don't know what exactly makes you do one versus another. But hopefully it's intuition, it's experience, it's humility, and so on.
Yeah, absolutely. Did you ever? That's wonderful stuff. Did you ever work with anybody from the Greeley Company over the years?
No.
So the Greeley Company, which is now owned by Chartis, specialized in medical staff elements such as credentialing, quality, peer review. And Rick Sheff, a former chief medical officer and educator and leader at the Greeley Company, used to teach what's called polarity management. And the essence of polarity management, and that's an MBA course, we're not going to do that on this show, is that resistance is your friend. Mm-hmm. So when you present or try to move to an idea, or like we talked about, you've mapped out your project and you're meeting with resistance, that is that aha. Is it me? Is it them? How do I listen better to the resistance and try to uncover what is at stake? And when do I push into the resistance? And he would teach that it's unlike in our medical training, it's not a problem to solve. It is a problem to manage. And you go in and out of that phase, as you're describing, of leaning in, listening, adjudicating, adjusting, and then pushing. And in through that resistance until you arrive at, like, we can't do this, or we can and we will, right?
Yes. Yes. Yeah. And I will say that a metaphor in the world of open surgery is, you as you gain experience, when to force breaking through tissue planes and when you just back off. And that's a very difficult, nuanced technique. Not everything is, not everything is meant to be forced through. And, the issue is all the external influences and our own icebergs. Because you start thinking, I'm not strong enough. I'm not being a strong leader. And people will say, you're waffling and, look, they pushed back and you gave in. And you realize it's important to listen, but it's also important to listen to your own voice and understand your own insecurities that have been a product of years of development.
Yeah. Well, waffling will get you burnt, and falafeling will get. No, just kidding. So this is good stuff. So what do you think are some of the key leadership tools that you have used in these difficult moments, aside from what we've already? Are there any other tools that you use in your leadership toolkit?
I think so much of the leadership world is about being self-aware. And I think that understanding your own intricacies, understanding what goes on and how you react to stimuli, it's kind of that concept of, Art Frankl of, between stimulus and response. It's what we do. That's why self-awareness is so important in this journey. I think the second sphere is learning the techniques of conflict management and team development and feedback, managing up, managing down, and understanding those relational issues. I think the final phase is really understanding how you interface with the system, whether your microcosm and the larger microcosm, and how do you create a system that has a culture, and what are the philosophies behind the culture? I'll conclude by saying this. I really believe theory and practice are important. I've met leaders who say, all these books are nonsense. Just figure it out. And I think we don't do that when we take care of patients. We don't just say, hey, go and you figure it out. We need to think about it. And I think whenever I take theory and apply it to practice, whether it's change management, whether it's team development, I think that it helps ground me in understanding why I'm doing what I'm doing and why I'm changing what I'm doing. And I think that at times it may seem trite. It may seem like you're trying to shine it, look smart in front of people. But I think if you can always take that view of the 30,000 feet and be able to dive down to 10,000 and go back up again, then I think as a leader, you are using all your competencies to serve, and always remembering the humility that you're there to serve those who you're leading. That again, as idealistic as it sounds, that leadership is a privilege that not everyone gets, and not all of us can hold on to it. And when do we hold on to it? When do we realize that we may be becoming a liability to what we care about? All of that, I think, goes into I think, being an effective leader.
Yeah. I'm going to borrow some of this when I do my executive teaching. It's spot on. You may have hinted at it a little bit, but I want to ask you what might have been the hardest thing for you personally in your role. What has been the hardest thing for you personally in your role?
I think the hardest thing personally, and I'll maybe use an example to illustrate it, is the concept that, we're taught as medical students and physicians that, work hard and everything's going to kind of go the right way. In leadership, what's so hard is that the concept that I may not be liked, that despite my hard work, that there are people who don't see the value. When I had started as an attending, I was good with giving autonomy, so residents loved operating with me. And then I became program director, and I'm like, this is going to be great. And suddenly I noticed the residents had pulled back. And suddenly the realization that concept of likability is not the measure anymore is very difficult. And I think that understanding, I had this expression to our residents. I would say, in the 5 years you're going to be a resident with me, you're going to most probably start liking me. You're going to dislike me at one point, and hopefully you'll end up liking me again. And what I meant by that was, it is difficult because if you want to do your job well, you need to take that off the table. And I think that for me personally, through the years, has been a difficult part of leadership.
And thank you for sharing that. That is, it's unique to each person that I ask, because it has to do with who you are as a person and how you're wired. Again, in management classes, right, you about a third of people will like you pretty much all of the time, and a third of the people you're with won't like you pretty much all of the time. It's that messy middle that we spend a lot of our time on.
Yes.
But to your point, here's what I believe. As young wannabe physicians, the first time you tell your family and friends, I want to go to medical school, the balloons, the confetti, the parade, oh my gosh, you are so wonderful. You want to become a doctor. And then you become enrolled in medical school and people say, what are you up to? I'm in medical school. More balloons, more confetti. You, to the external world, get into the bubble of the physician universe that still true today, despite all of the changes over the last few years. It is still a noble profession. People generally respect physicians. You are liked by the general public who doesn't know you. You are liked at parties. You are liked at events. People want you to speak, so on and so forth. But as a leader, it's a very, very different phenomenon. And as long careered physicians, realizing that there are more people than not who suddenly will question whether they like you. It doesn't mean they don't like you, but that's a surprise to most physicians. And you and I, as oncologists, have delivered awful news to lots of people under some of the hardest circumstances when they're at their most vulnerable. And we still get liked. I mean, yes. People get mad at us, and you and I have had that share. But when you think you've just delivered the most horrible thing to somebody and they say, thank you, or we love you, doctor, your heart just goes a pitter-patter, as Absolutely. They say. And yet as a leader, it doesn't happen that often.
No, it doesn't. We were at a session last night, and I was mentioning, remembering that leaders also are humans and have emotions and appreciate the Thanksgiving, well wishes, and so on. That's difficult. That's a very difficult journey in understanding that you have a mission and that issue needs to become less important. It's a difficult part of it. I think it's good to know and good to talk to people with more experience about it.
Would you? So let's follow that thread. So if we could go back into the time machine, what leadership pearls or life lesson pearls would you say to that young fellow walking around on M Street, and give them some little pearls as you know that journey will unfold?
Let's say 3 things come to my mind. One is that the external validations that we set for ourselves is not the criteria of how good you are at what you do. I remember I was in the chief residency class, and I did a lot for resident education and so on. And at the end of the year, when they gave the award for the best teacher, I came second, and I was devastated. And so understanding that the external validations have value, but they're not everything. The second thing is we're in this world to continuously get better until the day we're no longer here. And if you go with that philosophy, then you say, hey, listen, you know what? That didn't go so well. That's okay. I'm going to do better next time. Yep. And that concept that there's always a next time. So don't, you can lick your wounds a little bit, but then move on. The third piece is, I think, judgment is a big issue. Is that we are in a world which is constantly judging each other in a binary fashion. And as a leader, we're like, hey, that guy's a good fit. That guy's not a good fit. Or, maybe not being magnanimous. That guy's a loser. That guy's a winner. And we do these binary judgments. And maybe if anytime we come up with a binary judgment, we stop ourselves and say, let me not judge, but let me assess. You're a good resident, but you could be better if you do X. And so on. That's an assessment. And I think if we do that, that helps also the relationships with the people we serve, because we're not judging them anymore. It's not personal. It's an assessment. So to me, those 3 things, the external validations are not everything. We create all of these awards and so on, but they're only a piece of the puzzle. There's always room for improvement, and keep improving to the last day. Maybe less judgment and more assessment.
Very wise. And, you often could wonder in the thought experiment if a younger version of ourselves would listen to these pearls.
Absolutely.
Yeah.
And that's why time is essential.
Yeah.
Because no, if someone had told me this in 2005, I would be like, yeah, whatever. Let's move on. So yes.
Yeah. And that goes back to leaning in and stepping back and listening ever so carefully.
Yes.
So, so one last question for us to consider. So you've had a very strong career and experienced different health systems. And, there are those out there that state that the United States healthcare system is not a system, and I would agree. It's something other than a system. And if anything, it might even be characterized as a dumpster fire. And there are lots of fires going on in healthcare. Some are great, blazing, wonderful fires that we all get warmth from and protects us, and others quite the opposite. Any thoughts on what you think? What is the biggest fire in our healthcare universe today, and what can a chief medical officer do about that, if anything at all?
That's a wonderful question, and that's a topic of a whole hour conversation. I would put it this way. I think, in American healthcare right now, we're in the world of superlatives. I truly believe we constantly use the word, we have the best healthcare system in the world. And we're in the world of superlatives. In every system, how many top 100 hospitals are there? More than 100. So sometimes you're like, how could you have more than, it's like what we got in effect. I think one of the issues that we really have to deal with is the issue of compensation. We have evolved from a world of, take every other night call because you want your practice to do well, to a world where we're emphasizing well-being and time. And I totally support that. But yet we have made our compensation models completely become dependent on the productivity, on the clinical productivity of the physician. And this is not only true about community-based systems, but it's true about academic healthcare systems too. Many of them are on some form of an RVU-driven system. My worry is if my fulfillment and my sense of value is going to come primarily through my compensation, how are we going to keep up with this? It feels that we are in a world where basically we're saying, hey, you know what, Mo, I love you as an educator, but what's your clinical productivity? So we're putting value on clinical productivity, and totally understood that. Narrow margins, get all of that. But if all of our validation is going to come through that, I don't know that we can keep up with it. And I haven't seen anything that makes me think that there's a solution around the corner to this problem. And so as much as we are talking about value-based care, I worry that the fee-for-service is alive and in fact has transformed into something where the other things that give you value, whether it's academic endeavors, quality endeavors, and so on, have become subjugated to the clinical productivity.
One of our guests reminded me of an editorial. I believe it's an editorial in the New England Journal about a year ago this week, where the title mentioned the financialization of medicine. And I think it's a really insightful term. And that's what I hear when you are speaking about compensation, fee-for-service, value. But it really almost doesn't matter the system by which physicians and providers, and I mean providers as in hospitals, clinics, and all of the other non-physician folks. I don't like the pejorative of calling a doctor a provider, but there are providers of care, period. So everything has been financialized, and it is distracting and distasteful for most of us to think that the ultimate goal seems to be the finance, not the care of the patient. And it's something. So, like you, I don't know that there's a solution per se. I think there are a myriad of solutions. what I am hopeful about, and this show will help propagate this, is that this is the time that this conversation needs to reach as many listeners as possible. Absolutely. And you and I are no longer young men, and we since the 80s that everybody's been bemoaning. Hell, my senior partner was bemoaning when Medicare was called into action, was legislated into action. It's going to ruin medicine. Well, it didn't. It certainly has had an impact. I wouldn't say it's ruined it. And we've been talking about this for no less than 30 years and longer, but we're not having the right conversations.
Absolutely.
And it's time that we use the platforms available to expand and include more people and see what policy levers can be shaped and changed and alter the system. And again, we may never get it perfect, but to your earlier, we can do better tomorrow, and that's what we're supposed to be looking for, is trying to get better. So,
I'll just very quickly say, I took a course, Social Transformation of Medicine, in 1984. And at that time, they showed the curve and said, here's the cost of medicine in the U.S. That curve still is going up. Mm-hmm. And the way we are paying people, it's not going to break. And here we are. That was 1984. We're here in 2025. And the discussion's still the same discussion. And that concern, I mean, I'm an optimist, so nothing worries me. It concerns me.
Yeah, you have to take the long view. And it took us 40 years to figure out what a podcast is. So now we have a podcast, and there'll be some other media in a few years. But the conversation cannot stop. And it's a responsibility of leadership. You don't necessarily get to choose the conditions of the battlefield, but to the extent that you shape them and stop going to war over things, that's the ultimate goal of military men, is to not go to war. Yes. That's actually the intention, so to speak, to be strong enough and lethal enough that you don't have to do these things because the price you pay is too great. But sometimes you have to do things. So, and you're a surgeon, and you know what I mean? Sometimes you have to do things. So, listen, no small task being a chief medical officer, right? It takes a lot of intentional preparation, often feels like a trial by fire. And it was my old boss that inspired me to title this show. He said, it's just like a career in firefighting. You're a medical director, then you're a vice president, then you're a chief. You're a firefighter. You go to firefighting school, you train, you drill, you put on the uniform, you go out and fight a fire. And then one day somebody says, hey, maybe you should be the squad leader. Or they tap you on the shoulder and say, you should be the captain of the house. And then one day you find yourself being the fire chief or even the fire marshal, but you can't become a fire chief without first becoming a firefighter. So it certainly has relevance, I think. And it seems like you would agree with me.
Absolutely. Absolutely.
Well, it was a real pleasure having you on the show. I think our audience will have learned a lot of pearls and a lot of insights. And this is hopefully for our younger physicians who are, thinking about an executive pathway, and they may not have an immediate coach or mentor, and we can provide some of those lessons learned and pearls for them. And so for all of the listeners, if you want to find out more about what it's like to be a chief medical officer, you want to be on the show, email me at leescheinbart@gmail.com or connect with me on LinkedIn. You can listen to the podcast on Apple. You can also watch the videos of the show on YouTube. Our show's website is thefirechief.podbean.com. I love talking with chief medical officers from all over the United States, so please connect with me, leave your reviews and your comments, and please share this with your colleagues. And in the words of Sergeant Phil Esterhaus, let's be careful out there.